Well, good morning, everyone, and Happy New Year. We hope everyone had a wonderful holiday and enjoyed themselves. And welcome to Trio Maryland's first meeting of 2026. I'm Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. We'd like to welcome all our members and guests today, and thank you for attending. Today's topic is an exciting one: transplant vaccines navigating the current climate. It's all about vaccines and what is best for us transplant recipients. On February 14th, we also have a presentation done by Anatomy Gifts Registry, which is about whole body donation and research and science. We hope you all can make it. And now I'm going to turn the meeting over to Michelle to introduce our speaker today.
Good morning. Happy New Year. Diseases at UCLA. She's also an adjunct faculty at the University of Pittsburgh Medical Center, where she continues to carry out her research. She has previously served on the faculty at Johns Hopkins Hospital. Her current clinical focus includes providing infectious disease care for oncology patients, as well as solid organ and bone marrow transplant recipients. Her interests include CMV infection, fungal infections, as well as antimicrobial stewardship in the immunocompromised patient population. Dr. Meta Steinke attended the University of Buffalo Medical School, completed her residency training at Tufts Medical Center, and subsequently completed her fellowship training at UCLA, where she also earned a master's degree in clinical research. In her free time, she enjoys knitting, painting, and spending time with her family and dog Pebbles, who is there today giving her emotional support. We are so fortunate to have you back, Dr. Seema. You are one of our community's favorites. Thank you for addressing Trio Maryland's group. Thank you and welcome. And I now turn the program over to you.
Thank you. Thank you for having me. I always love speaking at Trio Talks. So the objectives for today's talk are to discuss why vaccines are essential for this unique population, summarize an understanding of vaccine strategies in the context of transplantation, review the recommended vaccines, and describe how the current political climate is impacting the development of vaccine hesitancy. So let's talk briefly about solid organ transplantation. So this involves replacing a diseased or damaged organ with a healthy one from a donor. Common transplants include kidney, liver, heart, lung, pancreas, small bowel, and any combination thereof. Immunosuppression is crucial for post-transplant care to prevent the recipient's immune system from rejecting the new organ. This suppression, however, creates an increased susceptibility to infections. Infection carries a significant morbidity and mortality in transplant recipients, and antibiotic therapies are essentially less effective in transplant recipients than non-transplant hosts because of the immunosuppression. So simple infections can certainly lead to worse outcomes in transplant recipients. So immunosuppression is actually considered a double-edged sword. Immunosuppressive medications are vital for preventing organ rejection, but these drugs weaken the immune system, thereby reducing its ability to attack the transplanted organ. This global weakening of the immune system essentially leads to an increase in the risk of opportunistic infections and vaccine-preventable diseases. The challenge is balancing immunosuppression to protect the organ while maintaining sufficient immune function to fight infections. Factors that can contribute to one's quote-unquote net state of immunosuppression can include the immunosuppressive drugs that people are on, so dose, duration, the regimen that they take, any underlying illnesses or comorbidities, and one's age. So what are some vaccine recommendations? It's important to vaccinate before transplantation whenever possible. And the recommended vaccines include all the childhood vaccines, but certain vaccines that some of us may not have been exposed to as a child, or vaccines that need to be boosted as we get older. So that includes the pneumococcal vaccine, hepatitis B, hepatitis A, varicella, MMR, the annual influenza vaccine, Tdap, which is tetanus, diphtheria, and pertussis, COVID-19, human papillomavirus, and respiratory syncytial virus. I'm going to go through most of these to discuss the infection a little bit, how it presents in transplant recipients, and then talk about the vaccine itself. Certain scenarios in transplant patients also requires administering the meningococcus vaccine. Age will factor into whether or not you get all of the above vaccines. For example, if you're 45 years or younger, we recommend the human papillomavirus. And if you're 50 years and older, we recommend the respiratory syncytial virus. So there's different types of vaccines. The first type is the live attenuated vaccine. So this contains a weakened version of the infectious agent. So it is actually alive in the vaccine. This is generally contraindicated in transplant recipients due to the risk of actually causing infection in the transplant patient. So we do not give any live vaccines after transplantation. It is crucial that any live vaccines that a person needs has to be given before transplantation occurs. So examples of live vaccines include the MMR vaccine, the chickenpox vaccine, so specifically the one that children get, oral polio vaccine, and some travel-related vaccines. The other type of vaccine that we have are inactivated vaccines. So you can see here there's a whole subset of vaccines that are considered inactivated, such as a subunit vaccine, a DNA vaccine, a viral vector vaccine, and an mRNA vaccine. Inactivated vaccines contain a killed infectious agent or parts of a killed infectious agent. So this is generally safe for transplant recipients. But efficacy overall may be reduced due to the presence of immunosuppression in a transplant recipient. Examples of inactivated vaccine include the influenza injection. There's two types of influenza vaccines, an injectable type and an intranasal type, so one that's inhaled through the nose. The inhaled one is actually a live vaccine, so we do not give that to transplant recipients. So the inactivated injection of influenza is what we give transplant recipients. The pneumococcal vaccine is inactivated, as is the hepatitis B and the Tdap vaccine. Because the efficacy may be reduced due to immunosuppression, we may require higher doses or more frequent boosters to achieve adequate protection. An example of such would be the COVID-19 booster, which, at least at UCLA, we recommend our transplant recipients receive once every 6 months. But this varies from institution to institution. So what are some common infections after transplantation? There's a schematic here on the slide that discusses various infections that can be acquired, but this list is very limited. There's hundreds and thousands of infections that transplant recipients are at risk for, and many of them we can try and prevent with vaccines. So transplant recipients are at higher risk for influenza, pneumonia from any cause, COVID-19, respiratory syncytial virus, and human papillomavirus. Vaccines play a crucial role in preventing these infections. Vigilance and preventative measures are still key in preventing infection as well. And prior to vaccinating a patient, we always weigh out the risks and benefits. So we review a patient's vaccination history, see what they've received, reconcile that with what they have not received, and try and bring patients up to speed. We assess their current immunosuppression levels and conditions to make a determination if it is safe to give certain vaccines at that time. We check for any other contraindications or allergies, and then we discuss the potential risks and benefits with the patient. Through this assessment, we can ensure safe and effective vaccination. So the timing of vaccination. So I've already kind of alluded to some of this, but pre-transplant is the most ideal time to give a vaccine because the immune system is more responsive, less suppressed, and therefore allows for a more robust immune response. Pre-transplant is a key window of opportunity, especially for live vaccines, which we cannot give after transplant. So, for example, if someone has lost immunity over time to measles, let's say, we can give the MMR vaccine, which is measles, mumps, and rubella, pre-transplant, but we cannot give it after transplant. So guidelines recommend at least 4 weeks between a live vaccine administration and proceeding with transplantation. So our window of opportunity for some critically ill patients can be quite small or even non-existent. So it's really important that if you're undergoing transplant evaluations, that your doctors really take a look at your vaccine history and make sure you are up to speed. Post-transplant, the timing of the uh, vaccination depends on the level of immunosuppression. Generally, we wait at least 3 to 6 months and sometimes 12 months after that transplant has occurred when one's immunosuppression is stabilized. We coordinate with the transplant team to optimize the timing for effectiveness and safety. And if someone is treated for rejection, then we generally wait 6 months after the rejection treatment to proceed with any necessary vaccinations. This is just a list of the vaccines that are needed. So the top half in white are the inactivated or the non-live vaccines. And the bottom half in gray are the live vaccines. So those are the ones that we would not give after transplant and only give prior to if it's indicated. So let's move into the different infections and vaccines that are recommended. So the influenza infection, also called the flu, is a common infection after solid organ transplantation and is associated with a very high morbidity and mortality. Infection with flu can actually trigger rejection of one's organ. So although vaccination is safe and effective, protection can be incomplete. So those who may be exposed to influenza are candidates for antiviral preventative medications, and transplant recipients who develop influenza infection should receive antiviral treatment regardless of one's vaccination status. So this year's influenza virus, I'm sure many of you have heard a lot about this in the news as it's quite rampant, but it's the subclade K strain of influenza A, also known as H3N2, that is circulating heavily. They call this strain Super K. It can spread rapidly and can progress quickly in patients. As of 12/30/2025, the CDC mentioned that there were 15 million cases of influenza K this season. This has led to 180,000 hospitalizations and 7,400 deaths from the flu. During the last week of December, there were specifically 1,259 influenza cases reported by public health labs. Of that, 1,223 were influenza A, and of that, 92% of them were the Super K strain. So there's a significant proportion of influenza out there that is being driven by Super K. So emerging data, however, so this is preprint data, mind you, so it has not yet been published publicly, shows that this year's influenza vaccine is generating antibodies against Super K. thus providing protection. So this is great news for us because the vaccine this year actually did not predict Super K and therefore did not necessarily include Super K in the vaccine, but it seems like there's some cross reactivity with some of the strains that are present in the vaccine this year. So vaccination efforts should be made to vaccinate a large proportion of the population. So the vaccine is an annual administration of the inactivated, so as I mentioned before, not the intranasal vaccine. And this is indicated for all transplant candidates, recipients, and their household contacts. For adult transplant recipients, so those 18 years and older, we prefer to give the high dose influenza vaccine in order to try and generate a stronger immune response in the transplant recipient. Let's move on to COVID-19. So those who are at risk for severe infection, as seen in this table here on the right, should be vaccinated against COVID-19. Immunosuppression may lower the threshold for infectious exposure needed to cause infection and can impair adequate immune control once infection is established. So you can see here on the right, there is different factors that can lead to severe COVID-19 infection. And down here at the bottom, we see solid organ or blood stem cell transplantation is one of those risk factors. And as we get older, we start to have more health conditions that we can acquire, such as heart conditions, diabetes, chronic liver or lung or kidney disease, cancer, and our age itself. So all these factors can combine and increase your risk for having severe COVID-19 infection. Donor-derived COVID-19 infection has been reported with lung transplantation, but not with any other organ types. And blood-borne transmission has not been reported and is not expected. We screen recipients prior to undergoing transplantation, and for non-lung recipients, if the recipient is positive for COVID-19, the approach on transplantation varies from institution to institution and depends on the recipient's severity of infection. So some institutions may say, oh, the infection is mild or without symptoms at all, we can proceed with transplantation. But if the infection in the recipient is severe or they're very ill with it, then we tend to hold off on transplantation in those situations. So let's briefly talk about the COVID-19 vaccine. So all solid organ transplant recipients should receive the COVID-19 vaccination with the most recent updated version, unless it's contraindicated for some reason, where, for example, you had an allergic reaction to the vaccine, then you should not receive it. Efficacy of vaccines are lower in solid organ transplant recipients than the general population, but the benefits still outweigh the risks. Solid organ transplant recipients should still adhere to protective measures despite vaccination. And this here is a table summarizing the moderate to severe immunocompromising conditions that may result in suboptimal COVID-19 vaccine response. So you can see here, one of the conditions is receipt of solid organ transplant or islet transplant, which is essentially a pancreas transplant, and taking immunosuppressive therapy. So solid organ transplant recipients are in the moderate to severe immunocompromising category that may result in suboptimal COVID-19 vaccine response. And we saw this quite clearly during the pandemic. And I've presented that data in a previous talk, so I won't go into it now. But despite that suboptimal response, having some protection is better than having no protection. So we still recommend getting this vaccine. So, along those same lines, breakthrough COVID-19 infection can occur despite vaccination. Breakthrough severe infection has been reported among solid organ transplant recipients, and one study showed that the risk of breakthrough infection was higher for heart transplant recipients, those of younger age, and for those who are most recently transplanted, so less than 3 months. Breakthrough infection rates, regardless, are overall very low. Therefore, vaccination is shown to be providing some degree of protection against the illness. So let's move on to RSV. RSV is respiratory syncytial virus. This is a common respiratory virus that causes common cold-like symptoms, but it can be a severe infection in solid organ transplant recipients. So factors associated with an increased risk of severe RSV disease include age that's older than 75, any chronic condition involving the heart or lung, end-stage renal or kidney disease, or dependence on hemodialysis, diabetes, chronic liver disease, obesity, persons with moderate to severe immunocompromising conditions as well. So what does that mean? That includes malignancy or cancer, receipt of solid organ transplant recipients, immunosuppressive therapy, and the list goes on. So it's really important that our solid organ transplant recipients are protected against RSV because they're at risk for having severe disease. So the vaccine is a one-time vaccine required for all transplant recipients 50 years of age and older. We do often vaccinate those less than 50 if they're undergoing a lung transplantation. The caveat to this is that it may not be covered by insurance. So this table here discusses which group of people would most benefit from vaccination, and it's adults 50 years and older and infants. Everyone age 75 and older should get RSV vaccine. And it's available any time of the year, but the best time to get vaccinated is actually late summer and early fall, right before we start to see an uptick in RSV infection. So let's move on to pneumococcus pneumonia. All solid organ transplant candidates and recipients should receive the pneumonia vaccine. The pneumonia vaccine is specific to a bacteria called Streptococcus pneumoniae, which we also call pneumococcus. Several studies show that the immune response to the vaccines are good, but can be diminished compared to non-transplant patients. This is very similar to the COVID vaccine. Yet we still recommend that our transplant recipients get the pneumococcus vaccine because it can be quite life-saving, actually. It protects very well against severe infection. So you may still get mild cases of strep pneumonia, but the severe cases should be blunted or mitigated because of vaccine. What about pertussis? We may be hearing a lot about this in the news as well because it's actually rising quite significantly. So it's transmitted by the bacteria called Bordetella pertussis. It's easily transmitted among children and adults. And the reported pertussis cases in 2023 was only about 7,000. But in 2024, that jumped up to about 35,000. This is reaching pre-COVID-19 pandemic levels. Studies have shown that this implies that COVID-19 measures where we were masking and social distancing and whatnot were actually preventing transmission of pertussis at that time. So now that we've relaxed our measures and people are no longer masking all the time, we are now seeing an uptick in whooping cough cases. Illness can cause severe disease and can be fatal in transplant recipients. But the Tdap, or tetanus, diphtheria, and pertussis vaccine, which should be given at least once every 10 years, provides protection against pertussis. Rising cases of tetanus are occurring as well, so this helps with protection against that also. And then we see here in the table this just discusses the symptoms that may be present in a transplant recipient. So they may have slight fever, mild or occasional coughing, a runny nose, and then you can, as the symptoms progress and time progresses, you can have prolonged, repeated, violent coughing episodes with a whooping sound when inhaling. So it's the that happens in between each cough that we call the whoop, and that is classic for whooping cough. Oftentimes, these bouts of coughing can lead to vomiting afterwards and just extreme exhaustion due to prolonged coughing. I have a YouTube video here that I'm not going to play now, but I'm sure you can look this up. It tells you or it shows you what the whooping cough sounds like in an adult. And as I mentioned, the whoop is the sound they make when inhaling between the coughing. So hepatitis A and B vaccines. Hep A is recommended for all adult liver transplant candidates and recipients. Hep A can result in fulminant liver failure, should be vaccinated as early as possible, and chronic liver disease can blunt one's immune response to this vaccination. But that being said, it's a two-vaccine series, and the first vaccine alone can result in about 90% protection. So it's really beneficial to get this hepatitis A vaccine. Hepatitis B vaccine is indicated for all solid organ transplant recipients, and we usually recommend doing a high dose vaccination. We check antibody levels 1 month after the full vaccine series is given, which is usually 2 doses. And if the antibody levels are not at 10 or greater, then we revaccinate the patient, sorry. The ideal timing for vaccination for hepatitis B is actually prior to transplantation, only because the response to the hepatitis B vaccine is greater and more robust when given prior to transplantation. So this here is just a table summarizing hepatitis A and hepatitis B. And we can see that hepatitis B in particular can be acute or chronic, with the chronic form leading to severe liver diseases such as cirrhosis, liver failure, and even liver cancer. So the vaccine in this case not only protects you against the infection, but it protects you against these chronic liver diseases, including the cancer. So here is an example of a vaccine that not only protects you against infection, but protects you against developing cancer, which is phenomenal. Human papillomavirus. So this is the common cause of common warts on hands, feet, and sometimes genitals. This is the cause of many head and neck, skin, cervical, anal, and penile cancers. Biologically female solid organ transplant recipients with human papillomavirus, also called HPV, infection are at a 20 to 100-fold increased risk of cervical cancer. Both biologically male and female recipients are at risk for anogenital cancers, so that could be anal or genital cancers. And one of the leading causes of cancer development in solid organ transplant recipients is from HPV. So this here is just a picture of a common wart on one's finger. It's very prevalent amongst young children, and so they've come out with the vaccine to protect the general population, but we highly recommend this vaccine in transplant candidates because of the implications that HPV has that we just discussed in transplant recipients. So vaccination should be given prior to transplantation whenever possible, but it can be given after transplant because it is not a live vaccine. In the US, the vaccine is approved through age 45. Whoops, sorry. So we generally recommend this vaccine for all of our patients 45 years and younger. There may be some indications to give it older than 45, but similar to the RSV vaccine, it may not be covered by insurance, and it's really a discussion that needs to be had with one's provider. It's very individualized and determined on an individual basis. So let's talk about varicella-zoster virus or VZV infection. This is also called the chickenpox virus. So most of us have been exposed to chickenpox either through illness or vaccination at some point in our lives. The chickenpox, if you get it through natural illness, will result in the widespread rash that's super itchy and usually keeps children out of school for a week or two. And then it progresses, usually to reside in the nerves of our body. And then it can come out during periods of stress. And when it reemerges during periods of stress, that's what we call shingles. Shingles in transplant recipients can be in one section of the body, so on an arm, on a leg, or it can be more severe and can be widespread throughout the body. That's called disseminated shingles. That can be associated with liver disease, it can be associated with pneumonia. So these various complications can occur as a result of disseminated shingles, which is why it's really important we protect our transplant recipients. So the vaccination, there's two formulations. There's a non-live vaccine called Shingrix and a live vaccine called Zostavax, which is actually no longer available in the US. But we avoid live vaccines in transplant recipients. One thing to note is that in our pediatric population who undergo transplantation, they cannot receive the chickenpox vaccine that is given to young children because it is a live vaccine. We recommend giving the non-live Shingrix to all transplant recipients since it is not a live vaccine. All solid organ transplant recipients should be vaccinated against VZV with the Shingrix vaccine, which is 2 doses spaced about 2 to 6 months apart. So let's move on to meningococcus meningitis. This is caused by a bacteria called Neisseria meningitidis. It is the bacteria that causes meningococcus meningitis. It is present worldwide, but most predominant in the meningitis belt of sub-Saharan Africa. It's spread through respiratory droplets and close contact. We often see outbreaks in the US in college dormitories amongst unvaccinated college freshmen. Certain populations are at greater risk for acquisition, and those are people without a functional spleen or without a spleen itself, and those receiving medicines that impact the complement system of the immune system. The complement system helps to specifically control bacteria like Neisseria meningitidis, which causes meningococcus meningitis. So this is a table which basically summarizes the groups of people that we generally recommend this vaccine being given to. And as I mentioned, the complement deficiency, and it lists some medications there like eculizumab or anatomic or functional asplenia, which is no spleen, and then persons with HIV. And then if you go down further on the table, it discusses people who like travel to countries where meningococcal disease is very endemic, college freshmen living in residence halls, microbiologists who are routinely exposed to this bacteria. We generally recommend vaccination for all these people. This is just a slide to show where the meningitis belt is in sub-Saharan Africa. So you can see that the dark blue is the meningitis belt, and the light blue or the lighter blue are countries with potential for meningitis outbreak. So the meningitis vaccine covers multiple strains that we call serogroups of Neisseria meningitidis. There's one vaccine that covers A, C, W, and Y serogroups, and the other vaccine covers the B serogroup. And we need to be vaccinated at least 2 weeks before any anti-complement medications are given or development of a non-functional spleen or removal of spleen. In the case of emergent spleen removal, we vaccinate after the spleen has been removed, but knowing that it does not protect you as well. And usually in these cases, despite vaccination, those without splenic function will receive antibiotics to also prevent infection with Neisseria meningitidis. So not only will you get the vaccine, but you will also get a preventative antibiotic. So let's move on to Haemophilus influenzae, which we also call Hib. The infection with Hib can cause infection ranging from minor to deadly. And there's increasing rates of infection in the recent years due to vaccination decline. And it can cause a variety of infections, specifically pneumonia, bloodstream infection, meningitis, epiglottitis, which is essentially infection in the throat, arthritis or bone infection, osteomyelitis, cellulitis, which is skin infection, ear infection, and pericarditis or endocarditis, which is infection specifically involving the heart. So the vaccine is recommended for adults who have a non-functional spleen or is without a spleen and is at risk for infection. And those receiving anti-complement therapies will also need to be vaccinated. So long-term monitoring post-vaccination in transplant recipients, we tend to monitor antibody responses after vaccination to assess effectiveness, and we consider booster doses if antibody levels have declined over time. Regular follow-up is required to ensure ongoing protection against vaccine preventable diseases. So I personally, with every clinic visit I do for all my patients, I review the vaccines and make sure that there's not anything they're missing that I could potentially give them that day to help boost their immune system and protection against vaccine preventable illnesses. So future directions for vaccination in transplant recipients. There's development of novel vaccine formulations that can elicit stronger immune responses in immunocompromised individuals. There's personalized vaccination strategies based on individual immune profiles. And there's research into new vaccines targeting infections that are common in transplant recipients. So there's a lot being done to improve the protection that transplant recipients may have in the future. But at this time, we have what we have, and we just have to make the best of what we have. So, what are some myths about vaccines and transplant recipients? The first one is that vaccines can cause organ rejection. Numerous studies over the years have debunked this, and none of the vaccines we've talked about thus far have ever caused rejection. Not during their initial studies, not during post-marketing studies. There's not even been a single case report for these vaccines causing rejection. So the myth of vaccines cause organ rejection is not really founded in any truth or reality. Recommended vaccines cause infection or illness. So, for inactivated vaccines, they stimulate an immune response, which generally feels like you're getting sick, but you're in fact not sick with the infection. So, for example, the COVID-19 vaccine generally makes people feel very unwell. Same with the shingles vaccine. But it's not necessarily infection from the vaccine. It is actually your immune response to that vaccine. So the sicker you feel, it kind of implies that the more robust of an immune response you're having, which is what we actually want. So not all vaccines make you feel sick, but some do. And it's not the infection from the vaccine, it's the immune response to the vaccine that's generating that feeling. Vaccines do not help with preventing illness, is another myth I've heard. Vaccines prevent many infections and even cancers, like we talked about. Specifically, hepatitis B and the human papillomavirus vaccines can help prevent cancer. And vaccination is a key preventative measure for solid organ transplant recipients. So, what are some challenges in vaccine uptake among recipients? There's barriers to vaccination, so psychological, like fear of side effects or organ rejection, social, so there's misinformation and lack of awareness, and logistical, so there may be difficulty accessing vaccination services and cost may be prohibitive for some people. Addressing these barriers is crucial to improving vaccine uptake. So let's talk briefly about vaccine hesitancy. Vaccines are among the most effective public health intervention out there. Significantly reduces morbidity and mortality from infectious diseases. And despite their proven efficacy, vaccine hesitancy has emerged as a global challenge. Misinformation, safety concerns, and political decisions have contributed to decreasing vaccination rates, posing threats to public health. Decades of evidence show that vaccines are safe, effective, and the most reliable means of protection from serious vaccine preventable diseases. Sorry for the typo there. The World Health Organization recognizes vaccine hesitancy as one of the top threats to global health, as this undermines herd immunity and equitable access to preventative care. Vaccine hesitancy varies across populations, varies among vaccine types and geographic regions. This is influenced by socio-cultural, political, and historical factors. And healthcare workers are a critical component to providing education and answering questions about vaccines to mitigate misinformation. So let's briefly talk about herd immunity. This concept became very publicly known during COVID, but it's something that the vaccine community has known for quite some time. It's also called community immunity, herd effect, population immunity, or mass immunity. It is essentially an indirect protective effect when a sufficient percentage of the population has become immune to an infection, either through infection or vaccination. So once herd immunity has been reached, disease gradually disappears and may result in eradication, or in fact, permanent reduction of infections to zero if achieved worldwide. Examples of this include polio, and at one point in time, measles was in this category. It's no longer in this category due to vaccine hesitancy and decline in vaccine rates of MMR. So, what are some barriers to vaccination? So, we have social determinants of health, structural barriers like actual physical obstacles to vaccination access, data limitations, so gaps in the collection, quality, and use of data that hinder the ability to identify disparities, etc. Policy constraints, so restricted or fragmented policies that are underfunded and understaffed. Messaging and education, lack of clear, consistent, and culturally relevant public health communication is present. So these are barriers to vaccination. This is a slide that basically shows vaccine uptake for Black, Hispanic, and other children of color compared to white children. The negative values indicate that the racial or ethnic group saw a larger decrease in vaccination coverage compared to white children. This is specifically for diphtheria, tetanus pertussis vaccine, hepatitis B vaccine, and MMR vaccine. And you can see that this is broken down by income group, high, medium, and low. So for example, let's look at the other children of color category. You can see for MMR in the low income group, I'm looking right down here in this corner on the right-hand side. In the low income group, the vaccination rates were almost -5 percentile difference. That is huge compared to the red line, which is 0, which would be no difference to white children. So you can see here that social determinants of health really drive a lot of these vaccination rates amongst children of color. And this is frightening. This should not exist in this country in this year. So I just wanted to put this slide out there to show you how these social determinants of health are actually truly impacting vaccination rates. Then there's drivers of vaccine hesitancy, so misinformation, concerns with safety or side effects, perception of low vaccine efficacy or importance, distrust in institutions. And this distrust in institutions is actually deeply rooted in the healthcare system. The impact of COVID-19 pandemic, religious, cultural, or political reasons, and agency and autonomy, so resistance rooted in feeling coerced or manipulated or lacking control in the decision-making process. So, what are some interventions that we can implement to improve vaccine uptake? So, we have population-specific tailored strategies, community engagement, improved accessibility, culturally and linguistically competent vaccine information, trusted messengers and workforce representation, provider recommendation, education and communication, policy priorities, and data quality and enhancement. So, the takeaway statements regarding vaccine hesitancy include overcoming vaccine hesitancy requires more than correcting misinformation or implementing one-size-fits-all policies. We need a comprehensive, equity-focused approach. It is necessary to rebuild public trust and address systemic barriers. Community voices in the development and delivery of various interventions is also crucial. So basically, we have to really steer a ship here in order to change the culture of vaccine hesitancy. So, not easily done, but small changes made within each community can potentially result in one large change overall. So, we really need to make better efforts here at changing vaccine hesitancy culture. So, conclusion, the vital role of vaccinations in transplant health. Vaccinations are essential for improving outcomes in solid organ transplant recipients. They reduce the risk of serious infections and even some cancers. They enhance long-term health. They improve quality of life. So, vaccination is a cornerstone of post-transplant care. So, vaccination really fits this quote by Benjamin Franklin that an ounce of prevention is worth a pound of cure. This is so true when it comes to vaccines. That ends my talk. I appreciate everyone's attention and putting comments in the chat. Let me stop sharing my slides and go to the chat here to answer some questions. Um, yes, most ERs are already overrun with flu patients. That is absolutely correct. I know in the ER at UCLA, I frequently am running down there to see new patients with flu. It's a real problem right now. The next question is, when should I test? That is, what indicators should I watch for to see if I have COVID or flu? Are there other over-the-counter methods to test for other illnesses? Great question. So definitely fever, cold symptoms like headache, cough, runny nose, sore throat. Those are all indications that you should check for flu or COVID. The other thing that flu tends to do that I've seen quite a bit of is just these severe muscle and joint aches and pains. This is definitely something that should trigger in your mind, I should check for flu or COVID. And are there other over-the-counter methods to test for other illnesses? Unfortunately, no, not to my knowledge. But you can go to urgent care and get broader respiratory virus panels that are done to check for other viruses that don't necessarily have treatments, but can certainly provide an answer as to why you're feeling what you're feeling. Next question. Does immunosuppression cause suboptimal response to targeted therapy like monoclonal antibody cancer treatments? So, no. To my knowledge, immunosuppression does not cause suboptimal response to monoclonal antibody therapies. It does cause suboptimal response to vaccines, but not monoclonal antibodies. I got a donor-derived infection. I was vaccinated for Hep B twice prior to transplant, 2 full rounds of 3 shots, and I never had titers pre-transplant. I now have Hep B from my deceased donor. My doctor encouraged me to accept a Hep C liver, full knowing I could not be could not be vaccinated against Hep B. I left my transplant hospital due to lack of care when my viral load became 96 million for Hep B. Yeah. This is a big reason why we really advocate for hepatitis B vaccination prior to transplant. But don't be alarmed if you're in the camp where you cannot mount an adequate immune response. In other words, you don't get full protection for hepatitis B pre-transplant. There are medicines we can give you after transplant to prevent the hepatitis B from being an issue. So if they knew your donor was hepatitis B positive, they should have given you some medications immediately after transplant, as well as repeated the vaccination series and then started medication for you to prevent the hepatitis B from being an issue. So I'm sorry that you had to experience what you experienced with your transplant center. Um, but I think this stems from perhaps lack of knowledge or lack of an appropriate protocol in place to manage hepatitis B positive donors. Um, Next question. If I recall correctly from when my dad was studying medicine, other Bordetella strains such as kennel cough are somewhat transmissible across species. Does our pertussis vaccine protect us against the animal strains of Bordetella? Excellent question. So I've talked about this in another talk. The Bordetella that causes kennel cough um, in our pets is one that can be transmitted to transplant recipients if our pet acquires kennel cough or they get the oral or intranasal vaccine, because those are live vaccines in our pets and they can be shedding that bacteria in their secretions and give it to the transplant recipient. Now, does our vaccine against pertussis protect us against these other strains of Bordetella? And the answer to that is no, it does not, which is unfortunate, but it doesn't. So I counsel my transplant patients and tell them that if they have a pet, to make sure that they get the injected version of the Bordetella vaccine for their pet, which is inactivated. So it is killed. So the pet does not shed that vaccine in their secretions, and that also leads to protection in the pet. So it's very important that you work with your healthcare provider, but also your pet's healthcare provider to ensure safety and health for yourself as well as your pet. Okay. Next question. I understand that symptoms are the immune system working. If an immune system is suppressed, will I even have symptoms, or do I have a misunderstanding or oversimplification of this process? No, that is correct. Oftentimes, transplant recipients don't have significant immune response to the vaccine, and therefore they may not have that robust response leading to that feeling of being sick from a vaccine. Um, but that being said, just because your response is blunted does not mean that you are not having a response. So you are likely having the response, but just not as strong of one. So you may, even the soreness in our arm is potentially our immune system doing something. So it's, it is the reality of the situation, unfortunately, but I do think that it is still important to get the vaccines, even though you're not having the symptoms from the vaccine, and it may still provide protection. I hope I explained that well. Um, to clarify, when looking at graphics of symptoms of disease, for example, whooping cough, are those for everyone, including persons who are immunocompromised? Yes, that is correct. I had measles, mumps, and chickenpox as a child. Does this provide me with permanent immunity, or should I have my titers periodically repeated? If you are a transplant recipient, you should have your titers periodically repeated. Um, Chickenpox will generally not wane. In other words, the levels will not disappear over time, but measles, mumps, and rubella, um, those titers can decrease over time and with age and with various underlying conditions. And as a result, you may need to be protected in some way. If you're post-transplant, we can't give you the MMR vaccine, but we can certainly provide you with education on how to protect yourself if there's a measles outbreak in your community or things of that nature. For example, I'm actually, thankfully, knock on wood, quite healthy, but my measles titer had waned over time, and I had checked it randomly for a job and realized I was no longer immune to measles, even though I had received my full vaccination series as a child. So I had to receive the MMR vaccine again in order to boost up my immunity against measles. So it is something that can wane over time, so it is important to periodically check titers. Are there ways to check if a person has been vaccinated but does not remember? Yes, we can check antibody titers. The example you gave is hepatitis B. That is easily checked. We just send off a hepatitis B antibody. We get the levels back, and it tells us whether or not you're protected. Which COVID-19 vaccine is best for us? Any of them. The mRNA vaccines are fine. The J&J vaccine is fine. Whatever you can get is better than not having one at all. Why transplant recipients' households should not take live vaccines. So after transplant, if someone needs to get a live vaccine, it's important to kind of quarantine that person from the transplant recipient. But otherwise, the household contacts should not get live vaccines. And that's because it causes shedding of the live virus or bacteria in that household contact. And when they shed it, they can spread it to the transplant recipient, and the transplant recipient can then acquire infection from that vaccine strain. And the vaccine strain tends to be usually resistant to antibiotics or antiviral therapies. So it's really important that we protect the transplant recipient at all costs. So if someone in the household needs to get, for example, the rotavirus vaccine, that's a common one given to children. It's a live vaccine, but can be shed in stool. So it's important that the transplant recipient not change that baby's diapers for 2 to 4 weeks after that baby has received the vaccine, because it can be shed in the stool, and then it can spread to the transplant recipient. So it's very complicated, but it's important to protect the transplant recipient. Interesting and informative. Thank you. Thank you. Thank you. Great information. I appreciate that feedback. Um, Congratulations on maintaining your professionalism while discussing vaccination hesitancy. I can't do it without swearing. Trust me, I have over the years learned that you can bring a horse to water, but you can't make it drink. So it is a sad reality of today's culture, and I deal with it daily at practice. And so I've had a lot of experience having to remain calm. So, but I appreciate that. Thank you for a great meeting. Very important information. Is it too late to get a flu vaccine? Absolutely not. You should get it if you haven't gotten it this season. Um, yeah, you can get it up until March and still have it be effective. Flu season runs from September through April, so you can certainly still get it.
Well, Dr. Seema, this was awesome. And we appreciate that Scott wasn't live on the call so that we missed any of his
Swearing.
swearing, and we can appreciate that. But this was great. We try to stay on top of Marty's vaccines, but I think we need to go back and revisit and make sure we've done all the things that we need to do. And I hope this was helpful for everyone. So thank you for your time. Everyone seemed to love it. And someone just posted a message here about being at the airport. I live in North Carolina, where we are having measles reappearing, including the Raleigh-Durham Airport. They're a lung transplant recipient. How concerned should they be?
Um, I would be concerned. I would wear a mask and practice hand hygiene, especially when you're out in public places. I know that North Carolina is having a surge in measles. Yes, take protective precautions as much as you possibly can. I think wearing a mask, specifically if you can get your hands on an N95 or KN95, that would be preferred. But if you can't, then at the very least, a regular surgical mask is better than no protection whatsoever. Measles can cause severe pneumonia, especially in a lung transplant recipient. It can be fatal. So take the necessary precautions to protect yourself.
Thank you. Thank you. And one of our transplant centers has already required masking when in the hospital. So some
Yeah.
changes are being made here locally. But
Yeah.
Well, we want to thank everyone for attending today. We love seeing your smiling faces, especially you, Linda. I hope you're soon feeling better. We're all praying for you. Check out our events page on our website for our advance notices of our future meetings. Our website address is www.triomaryland.org. All of our past meetings are posted to our YouTube channel for your convenience. Have a great weekend, and may your football team still be playing.